Good afternoon, everyone. My name is Iyan Younus. I'm a sixth-year neurosurgery resident at Vanderbilt. Thank you to the scientific committee for allowing us to present this work today, which was conducted in the combined orthopedic neurosurgery Vanderbilt Spine Outcomes Lab under the mentorship of Dr. Scott Zuckerman. So, as a very brief introduction, this landmark study by Picenti et al. Demonstrated that in a cohort of healthy volunteers, the L4-S1 lordosis typically ranges between 35 and 45 degrees, regardless of pelvic incidence. And this was further borne out in more recent studies by Hills and Kelly et al. Involving the T4-L1 hip axis, in which you'll see in that box outlined in the red circle that despite PI, the mean L4-S1 lordosis really ranged from 35 to 45 degrees. And so we try to attain these goals intraoperatively, and we assess if these goals are met with intraoperative x-rays. However, it's actually not quite well understood whether these intraoperative x-rays actually match the postoperative x-rays. And so the objective of this study is in patients undergoing adult spinal deformity surgery, we sought to evaluate the direction of change in L4-S1 lordosis and the magnitude of change between the last intraoperative full cassette x-ray and the first standing scoliosis x-ray. So this is a single institution retrospective case series. The standard adult spinal deformity inclusion criteria, the primary outcome again is the intra-op to post-op L4-S1 lordosis. And specifically, the intraoperative x-rays were measured on the final long cassette x-ray with the rods and set screws in place. And the post-operative x-rays were the first standing scoliosis films, usually prior to discharge or at the first follow-up within 2 to 6 weeks. This is an example of that measurement. The panel on the left side shows the intraoperative measurement of the L4 superior end plate to the sacral end plate. And so 120 patients met inclusion criteria. The preoperative lordosis was 32 degrees. Total instrumental levels were 10. 15% of patients had pedicle subtraction osteotomies, and a third of patients had an interbody. This shows the overall results for the entire cohort. So intraoperatively, the mean L4-S1 lordosis was 38 degrees, and postoperatively, the mean lordosis was about 34.5 degrees. That represents a 4-degree decrease in all patients. This shows that for the majority of patients, 70%, they saw a decrease in their intraoperative to postoperative lordosis. And then finally, looking at this in an even more granular fashion, we wanted to pinpoint the patients that saw a greater than 5-degree change. That accounted for about 32% of the cohort. And when looking at these patients, interestingly, younger age was associated with this change, but no other intraoperative factors such as 3-column osteotomy, interbody, instrumental levels, or multi-rod constructs were significant. And so, in conclusion, we saw a mean 4-degree difference in intraop to post-op L4-S1 lordosis. About a third of these patients had a change greater than 5 degrees, and almost all of these patients, except for 2, had a decrease in lordosis. We found that younger age was associated with this, which we don't quite understand. And so in kind of theorizing why this occurs, first, you're comparing a prone film with anesthesia and possible muscle relaxation to an upright film with gravity. And so there's possibly some minor cage subsidence, some pedicle screw settling, and even rod settling that may occur. And finally, there are several limitations to the study, including measurement error. And then our further goals with this study are to look at the clinical significance of this, particularly the impact on patient-reported outcomes and mechanical complications. But I think a take-home is consider planning for a slightly higher L4-S1 goal, maybe by about 4 degrees, to account for this finding. Thank you so much for your attention, and I'd like to thank Dr. Scott Zuckerman and Dr. Harsh Jain for their help with this study.
I have no slides as a discussion for this one, but it's another interesting paper from the busy Vanderbilt Spine Group. These are concerning findings, especially when there's a 5-degree change at L4 to S1. So the issues that are concerning are methodologically, was the intraoperative imaging done after the true final tightening? I know sometimes my partners get a little excited in the OR and it's like, oh, that looks good enough. And so we'll just accept that as the final x-ray. And then the accuracy of measurements are a challenge. Typically, we've said 5 degrees is the appropriate measurement threshold for variability greater than our precision. Yet I'm not sure that's exactly accurate when we're measuring at the lumbosacral junction. There's been some questions about that. And then there's questions about landmark alteration from interbody cages, imaging modality issues with parallax versus slot scanning technology. And so those are all questions about the signal-to-noise ratio. If, however, it is real, from non-weight bearing to weight bearing, then the change has to occur in one of 2 ways. Either the screws are plowing or the rod is unbending. Both of those can actually be analyzed, I suspect, from your data set by simply measuring the screw end plate distance or angular relationship. And then for the rod unbending, either the radius of curvature or a superimposition technique. So I look forward to seeing the answers to these challenging methodologic problems that we face, either in the published manuscript or maybe next year here on the podium. Thank you very much.
Thank you.